Welcome to Pediatric Case Review, Musculoskeletal Series. Today's lecture is a comprehensive case-based review of Holt-Oram syndrome, a rare but important genetic condition combining upper limb malformations with congenital heart disease. We will cover 11 carefully designed clinical cases exploring clinical presentation, pathophysiology, examination findings, investigations including imaging and genetic testing, treatment strategies, complications, and multidisciplinary management. Whether you are a pediatric trainee or a practicing clinician, this lecture will sharpen your recognition and management of this unique syndrome. Let us begin. Question 1. Clinical presentation. A 6-year-old boy is referred for evaluation. His mother notes he has always had an unusual appearance of both hands since birth. On observation, his thumbs appear elongated, slender, and positioned more like fingers rather than opposable thumbs. His left upper limb appears shorter than the right. Family history reveals that his father has a congenital heart defect. Option A, Poland syndrome. Option B, Holt-Oram syndrome. Option C, Vactral association. Option D, Fanconi anemia. Which diagnosis best explains this clinical presentation? The correct answer is option B, Holt-Oram syndrome. This condition is caused by a mutation in the TBX5 gene and follows an autosomal dominant inheritance pattern. The hallmark features are preaxial upper limb defects, particularly thumb and radial anomalies, combined with congenital heart disease in approximately 75% of cases. The bilateral but asymmetric limb involvement and the positive family history of congenital heart disease strongly support this diagnosis. Poland syndrome affects one side only and involves the chest wall. Vactral association includes vertebral and renal anomalies. Fanconi anemia presents with bone marrow failure in addition to limb defects. Question 2. Pathophysiology. Holt-Oram syndrome is caused by mutations in a transcription factor gene critical for both cardiac and upper limb embryonic development. Which genetic mutation is responsible for Holt-Oram syndrome and its dual cardiac limb phenotype? Option A, TBX5 gene mutation on chromosome 12q24. Option B, GATA4 gene mutation on chromosome 8p23. Option C, NKX2-5 mutation on chromosome 5q35. Option D, JAG1 mutation on chromosome 20p12. The correct answer is option A, TBX5 gene mutation on chromosome 12q24. TBX5 encodes a T-box transcription factor that is essential for both forelimb patterning and cardiogenesis during embryonic development. When TBX5 is mutated, two parallel pathways are disrupted. First, impaired forelimb bud patterning leads to radial and preaxial defects. Second, defective cardiac septation leads to structural heart defects, including atrial septal defect, ventricular septal defect, and conduction abnormalities. The inheritance is autosomal dominant with nearly 100% penetrance, but variable expressivity. Approximately 30 to 40% of cases arise from de novo mutations with no family history. Question 3. Clinical presentation. A newborn girl is noted at delivery to have hypoplasia of the left thumb and a short left radius. On cardiac auscultation, a fixed split-second heart sound is heard with a systolic ejection murmur at the left upper sternal border. Her father reportedly had open heart surgery as a child. No vertebral or renal anomalies are noted. What is the most likely diagnosis and associated cardiac lesion? Option A, limb defects only, no cardiac significance. Option B, pattern is consistent with thrombocytopenia absent radius syndrome. Option C, this pattern is consistent with Holt-Oram syndrome with likely atrial septal defect. Option D, features suggest Noonan syndrome with pulmonary stenosis. The correct answer is option C, Holt-Oram syndrome with atrial septal defect. Atrial septal defect is the most common cardiac defect in Holt-Oram syndrome, occurring in approximately 40% of affected patients. The classic auscultatory finding of a fixed split-second heart sound is the hallmark of atrial septal defect and does not vary with respiration. Ventricular septal defect is the second most common structural defect, seen in around 30%. Conduction defects including first and second-degree atrioventricular block are also recognized features. The positive family history of open heart surgery strongly supports autosomal dominant inheritance, making Holt-Oram syndrome the most fitting diagnosis. Question 4. Examination findings. A 3-year-old boy with known Holt-Oram syndrome is brought for a routine pediatric visit. His parents want to know what musculoskeletal findings you would expect on physical examination. He walks normally. Upper limbs are noted to be asymmetric. Which examination finding is most characteristic of Holt-Oram syndrome? Option A, absent clavicles bilaterally with drooping shoulders. Option B, short stature with rhizomelic shortening of all four limbs. Option C, camptodactyly and syndactyly of fingers 3 and 4 bilaterally. Option D, triphalangeal or hypoplastic thumbs with radial ray anomalies and possible forearm shortening. The correct answer is option D, triphalangeal or hypoplastic thumbs with radial ray anomalies and possible forearm shortening. Holt-Oram syndrome produces a spectrum of upper limb defects that are always preaxial, meaning they affect the radial side more than the ulnar side. The mildest presentation is a triphalangeal thumb, where the thumb has 3 bones instead of 2 and resembles a finger. More severe forms include absent or hypoplastic thumb, radial hypoplasia or aplasia, and in the most severe end, phocomelia. The defects are always bilateral but are often asymmetric, with the left side typically more severely affected. Lower limbs are never involved, and absent clavicles suggest cleidocranial dysplasia rather than Holt-Oram syndrome. Question 5. Examination findings, cardiac. During a well-child visit, a 5-year-old with known Holt-Oram syndrome undergoes routine examination. He has no respiratory symptoms. Vital signs are normal. His cardiologist last saw him 2 years ago. On auscultation, you note an irregular rhythm without murmur. What is the most appropriate interpretation of this finding in the context of Holt-Oram syndrome? Option A, likely atrial fibrillation. Conduction defects are a recognized feature of Holt-Oram syndrome. Option B, this is a normal variant. No action needed. Option C, likely ventricular tachycardia requiring immediate cardioversion. Option D, this finding is unrelated to his syndrome. The correct answer is option A, likely atrial fibrillation, as conduction defects are a recognized feature of Holt-Oram syndrome. Conduction abnormalities in Holt-Oram syndrome occur independently of structural heart disease because TBX5 directly regulates genes controlling the cardiac conduction system, including HCN4 and connexin 40. These abnormalities include first, second, and third-degree atrioventricular block, atrial fibrillation, and sick sinus syndrome. They can appear at any age, including childhood, and tend to be progressive over time. All patients with Holt-Oram syndrome require an electrocardiogram and Holter monitoring at regular intervals regardless of structural cardiac status. Cardiology referral is mandatory whenever an arrhythmia is detected. Question 6. Investigations. A 2-day-old neonate is noted to have bilateral upper limb anomalies, including an absent left thumb and a hypoplastic right thumb. A cardiac murmur is detected. Parents inquire about the diagnostic workup. Chromosomal microarray ordered by genetics is normal. What is the most appropriate next diagnostic step? Option A, reassure parents. Normal microarray rules out genetic condition. Option B, perform renal ultrasound only, most likely VACTERL association. Option C, order TBX5 molecular genetic testing, perform echocardiogram and electrocardiogram. Option D, order full skeletal survey for all limbs and spine, no cardiac workup needed. The correct answer is option C, order TBX5 molecular genetic testing and perform echocardiogram and electrocardiogram. This is a critical teaching point. A normal chromosomal microarray does not rule out Holt-Oram syndrome because TBX5 mutations and small intragenic deletions are not detectable by microarray. Targeted molecular sequencing of TBX5 or deletion duplication analysis using multiplex ligation-dependent probe amplification is required. The cardiac workup must include echocardiogram to detect structural defects and electrocardiogram to assess the conduction system. Hand and forearm X-rays are used to document and characterize the radial ray anomaly. If TBX5 sequencing is positive, first-degree relatives should also be evaluated and screened. Question 7. Investigations, imaging. A 4-year-old with suspected Holt-Oram syndrome is sent for upper limb radiographs. The radiologist calls you to describe the findings shown on the image. What do these radiographic findings represent? Option A, these X-ray findings suggest osteogenesis imperfecta. Option B, these changes are consistent with juvenile idiopathic arthritis. Option C, findings suggest thrombocytopenia absent radius syndrome. Option D, radial ray hypoplasia with triphalangeal thumb, consistent with Holt-Oram syndrome. The correct answer is option D, radial ray hypoplasia with triphalangeal thumb, consistent with Holt-Oram syndrome. The key radiographic features of Holt-Oram syndrome on hand and forearm X-rays include radial hypoplasia or aplasia as the most common bony finding, an absent or triphalangeal thumb, scaphoid or trapezium aplasia or fusion, carpal bone anomalies, and in severe cases humeral hypoplasia. An important distinguishing point, thrombocytopenia absent radius syndrome also has absent radius on X-ray, but in that condition the thumbs are always present. In Holt-Oram syndrome, thumb anomalies are universal. The involvement is bilateral with the left side typically more severely affected than the right. Question 8. Diagnostic criteria. You are evaluating a child with isolated congenital heart disease and no visible limb abnormalities. Genetic suspects Holt-Oram syndrome. Which statement best describes the diagnostic criteria for Holt-Oram syndrome? Option A. Holt-Oram can be diagnosed with TBX5 mutation alone, even without obvious limb defects. Option B. Diagnosis requires both structural congenital heart disease and upper limb malformation. Option C. Diagnosis requires phocomelia to be present. Option D. Isolated cardiac conduction defects cannot be the presenting feature. The correct answer is option A. Holt-Oram syndrome can be diagnosed with a TBX5 pathogenic variant alone, even without obvious limb defects. Diagnosis can be made on two grounds. Clinically, the classic requirement is the presence of an upper limb anomaly combined with either structural congenital heart disease or a cardiac conduction defect. However, genetically, a confirmed pathogenic TBX5 variant is sufficient for diagnosis regardless of the phenotype. This is important because phenotype is highly variable. A minimal limb defect, such as a subtle carpal bone anomaly visible only on X-ray, may be the only skeletal finding. Phocomelia is the most severe end of the spectrum, not a requirement. Isolated conduction defects without structural heart disease are a recognized and valid presentation. Question 9. Treatment. A 6-month-old girl with confirmed Holt-Oram syndrome has a large secundum atrial septal defect with right heart volume overload on echocardiogram. Her left hand shows an absent thumb. Parents ask about management. What is the most appropriate management plan for this infant? Option A. Watchful waiting only. No intervention needed before school age. Option B. Start oral anticoagulation and defer all surgery. Option C. Cardiac catheterization for atrial septal defect closure plus hand surgery referral for thumb reconstruction or policization. Option D. Only hand surgery is needed. Atrial septal defect will close spontaneously in all cases. The correct answer is option C. Atrial septal defect closure plus hand surgery referral for thumb reconstruction or policization. A hemodynamically significant atrial septal defect causing right heart volume overload requires intervention, either catheter-based closure or open surgical repair, depending on the defect size and anatomy. This should not be deferred. For an absent thumb, the procedure of choice is policization, where the index finger is surgically repositioned and reconstructed to function as a thumb. This is ideally performed between 12 and 18 months of age to maximize functional hand development. Radial club hand deformity may require centralization or radialization surgery. Occupational therapy and prosthetics are additional components of limb rehabilitation. Regular lifelong cardiology follow-up is mandatory for all patients. Question 10. Treatment, multidisciplinary. The parents of an 8-year-old boy with Holt-Oram syndrome ask which specialist should be involved in his long-term care. He has a repaired ventricular septal defect, mild right radial hypoplasia, normal thumbs, and a recent Holter showing occasional second-degree atrioventricular block. Which management approach is most appropriate for this child? Option A. Orthopedic surgeon only. Option B. Cardiologist only. Limb anomaly is mild. Option C. Multidisciplinary team including cardiology, orthopedics, genetics, occupational therapy, and developmental pediatrics. Option D. No specialist follow-up needed after ventricular septal defect repair. The correct answer is option C. Multidisciplinary team management. Holt-Oram syndrome affects multiple systems and requires lifelong coordinated care from several specialties. Cardiology is essential for monitoring structural defects in the progressive conduction disease. An annual electrocardiogram and Holter are recommended. Orthopedic surgery manages limb reconstruction, including radial ray and thumb anomalies. Clinical genetics provides family counseling, TBX5 testing coordination, and genetic risk assessment. The recurrence risk for each first-degree relative is 50%. Prenatal diagnosis is available through TBX5 molecular testing, and prenatal ultrasound may detect limb and cardiac anomalies. Developmental pediatrics and occupational therapy support school performance and hand function. All first-degree relatives of an affected individual should be clinically evaluated. Question 11. Complications and associations. A teenager with Holt-Oram syndrome has been doing well after atrial septal defect repair at age 2. At age 14, routine Holter monitoring shows progressive first-degree atrioventricular block that was previously normal at age 10. He is asymptomatic. What does this finding tell you about conduction disease in Holt-Oram syndrome? Option A. Progression of conduction defects is not expected in Holt-Oram syndrome. Seek alternative diagnosis. Option B. This is a medication side effect. Stop current medications. Option C. Pacemaker should be implanted immediately regardless of symptoms. Option D. Conduction defects in Holt-Oram syndrome are progressive and can worsen over time. Continued monitoring is essential. The correct answer is option D. Conduction defects in Holt-Oram syndrome are progressive and can worsen over time, making continued monitoring essential. This is one of the most important clinical pearls in managing Holt-Oram syndrome. Conduction disease follows an age-progressive course, evolving from normal rhythm to first-degree block, then second-degree block, and potentially complete atrioventricular block. This progression occurs independently of whether structural heart disease is present or has been repaired. Annual electrocardiogram and Holter monitoring are therefore recommended throughout life. Pacemaker implantation is indicated for symptomatic bradycardia, high-degree atrioventricular block, or sixth sinus syndrome, but not for asymptomatic first-degree block alone. This case highlights why lifelong cardiac surveillance must never be discontinued after cardiac repair. We would like to take a moment to tell you about our Pediatric Case review community on Patreon. If you find these lectures valuable, you will love what the community has to offer. All videos are organized by system, so you can access every lecture in one place sorted by pediatric specialty, making revision structured and efficient. All presentations used in the videos are also available as photos, so you can read through them, review the cases, and practice all multiple-choice questions at your own pace. The community also features case-based questions ideal for exam preparation and clinical training. If you're interested in joining and would like details on how to subscribe, simply comment below in this post, and we will message you directly with everything you need to know. And that brings us to the end of today's lecture on Holt-Oram syndrome. Let us quickly summarize the key takeaways. Holt-Oram syndrome is caused by a TBX5 mutation on chromosome 12q24 and follows autosomal dominant inheritance. The hallmarks are upper limb radial ray defects combined with cardiac defects, with atrial septal defect being the most common. Conduction disease is progressive and requires lifelong monitoring. Management must be multidisciplinary, involving cardiology, orthopedics, genetics, and occupational therapy. Genetic counseling is essential given the 50% recurrence risk. Early diagnosis enables timely cardiac and surgical intervention that can significantly improve outcomes. If you found this lecture helpful, please follow the Pediatric Case Review channel for more case-based musculoskeletal and pediatric lectures. If you have any questions or comments, drop them below. We read every single one. Thank you for watching.